Hello, I'm Dr. Omar Bey, and welcome to OBHealthy's Doctor's Lounge. We are a group of Black physicians, and we're here for two main reasons. Number one, to improve the health of people of African descent. No matter where they come from, where they are, we're here to improve their health knowledge, number one. Number two, to encourage young Black men to go into medicine because it's a crisis. It really is a crisis, and we need our young men to think about medicine. If you're going to college, please think about medicine, all right, to be a physician because we need you. The other thing is that our webinar is every second Saturday at 1 o'clock. And note that if you want to see our prior webinars, all you have to do is go to OBHealthy, click on the YouTube sign, and all of our prior webinars are there. And go in and check them out. I really feel that there are a wealth of knowledge as far as we as Black people learning about medicine, about our bodies. That's so important. Okay. I would like to thank OBHealthy for allowing us to bring this webinar to you and supporting us. Um, Type in your question. Do not be hesitant to type in your question. We're here truly to answer your medical questions. And so don't hesitate. Type it on in. Okay. The most important thing I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor, believe me, only your doctor can truly take care of you from a medical standpoint. All righty. I'd like to let each physician introduce themselves, and then I'm going to tell you a little bit about our format that we're going to have today. Dr. Sprott, please, can you introduce yourself?
I'm Kendall Spratt. I'm a retired pediatrician. I did general pediatrics and critical care pediatrics.
All right, excellent. Dr. Waldron, you're next.
My name is Fred Waldron. I'm one of the emergency physicians at Newark Beth. I have been practicing by myself as an attending physician since 2002. I graduated from the medical school in Newark and did residency in Brooklyn.
Excellent, excellent. Thank you. Dr. Atherley, please.
Hi, my name is Trevor Atherley. I'm an interventional cardiologist. I practice predominantly out of Newark Beth Israel Medical Center. Good to be here.
All right, thank you. Dr. Salam.
Good afternoon, everyone. It's a delight to be here. My name is Dr. Kareem Salam, board-certified adult and child and adolescent psychiatrist. I run an adolescent unit in the city of brotherly love and sisterly affection, more commonly known as Philadelphia. A graduate of Robert Wood Johnson Medical School about 25 years ago. Completed residency at Temple University in North Philly, and completed child fellowship at Jefferson in Center City, Philadelphia. Again, it's a pleasure to be here.
All righty. Thank you. Thank you. And Dr. Court, please.
Good afternoon, folks. My name is Dr. James Court. My practice is located in East Orange, New Jersey. My specialty is internal medicine. I graduated from Harvard University in 1980.
All right. Excellent. Excellent. And I'm Dr. Omar Bey, pulmonary critical care physician and with a subspecialty in nutrition. And I'm so happy and just pleased that we can bring this webinar to you. Okay, so our topic today, and basically we're going to step back because I understand that we have all of these diagnoses that and talk about all of the medical, problems and stuff like that. But I'd like to just step back and let the physicians talk about several things. Number one, choosing a doctor. If you're dissatisfied with your doctor, what do you do? Proper medical care. What is proper medical care? How to navigate the hospitals, and those hospitals can be tough to navigate either for the patient or the family. Doctors' offices, ER, things like that. When you come into the ER, exactly what is this maze? Why did they take that patient and didn't take me in first? Things like that. And we have several other topics that I'd like to, attack before we, end the show. But let's start with the basic stuff, navigating our medical system. Let's start with choosing a doctor. I mean, Dr. Sprock, I'm just going to attach it to you. But before I do that, hold on. Dr. Patrick Anderson came on. How you doing, Patrick?
Uh, Good to be here, guys. I'm struggling to make it. I have some conflicts, but I'm here.
All righty, brother. We appreciate it. Can you introduce yourself? Because we just introduced.
Hi, everyone. It's always an honor the second Saturday of every month to be on this panel with mostly all of them my professors, and then my twin brother just joined. There's Patrick and there's Frederick, and they can hardly tell the difference between us. But
Nice to see you, my brother.
So glad to be here. I'm Patrick Anderson. I'm a GYN oncologist. I work out of Newark Bethesda Medical Center. Glad to be here.
All righty. Excellent. Excellent. Dr. Sprock, can you start us off with choosing a doctor? As far as choosing a doctor, I think it's the most important thing in the world because our bodies is the most valuable thing that we own. And how do we choose that person to take care of it? Can you give us some of your thoughts?
Omar, this has changed over the years. So initially, when a lot of physicians were in private practice, they either had a small group or they practiced solo by themselves. That's changed fairly dramatically over time. And part of the pressure to have that transition to larger group practices or larger specialty practice has been related to the impact of insurance and the insurance contractual relationship with either individual physicians or groups. And so depending upon what your insurance policy has, there are physicians that will be within that insurance group or panel that you get to choose from. Now, there are certain situations where if you have an insurance policy that allows you a great deal of choice, you can see other physicians outside of what the insurance panel is, but you usually have to pay a little bit more for that. And it could be substantially more. But I think that a lot of the importance of who you choose might be related to individuals that you might have or in the health profession. I always thought it was a good idea that if you saw a physician or a physician, to ask who their physician is. And if they have a specialist, who they will go to. Because in general, if the physician is interested in their own medical well-being, then they'll choose physicians that they trust and they know will treat them appropriately. The same thing goes with if you have members in your family that are in the nursing profession. A lot of the nurses will tell you, especially if you're talking about nurses that are in hospitals, who they might go to or who they think might be a good choice. A lot of what happens these days are there are a number of different entities that will evaluate physicians. And they'll give the 1 to the 5 stars just like they do with some of the restaurants and things like that. And so sometimes that will be another way that you can evaluate the number of stars. And then it's important to sort of look at some of the comments that might be related to that. Because if there are physicians that don't give feedback from the results of lab tests or things like that, or there have been problems either with the staff or things like that, you might see some of those negative comments. Now, those individuals that have the 5 stars, and again, you might look at the number of comments or reviews that they might have, that will give you some sense. It doesn't necessarily mean that because they have the 5 stars that they're the best physicians, but usually that encompasses their front office, their receptionist, their either some of the practice will have nurse practitioners or physician's assistants that are there. And there's a sort of a pecking order in terms of if you go or you choose a doctor, whether or not you get to see that doctor. The same thing happens about, well, if it's after hours. And more after hours means people will go to urgent centers where they don't see the physician. And hopefully they'll, in some practices, are setting up situations where you can see someone within that group. So I think it depends upon what your insurance is, where you are, and the reputation or the evaluations of a lot of the physicians that are there in terms of who it is. But if you have family members that are comfortable and happy with their doctors, you ask them why. And I think that you should ask those physicians that you're considering going to about what questions that you might have. In pediatrics, the issue is one of newborns. You know, if you're just having a child for the first time, and you know that there are a number of physicians that are there, very often the obstetrician gynecologist that you go to might have knowledge about the physicians. That's a little less likely in these days, because in these days, a lot of the pediatricians no longer go to the hospital. And a lot of times pediatricians would go to the hospital and be there for deliveries, especially in some areas where there are, you know, not as many people. Pediatricians would attend deliveries, especially difficult deliveries. But in urban areas, large urban areas, most of the times the neonatologists are those that take care of the critically ill newborns are there. And a lot of pediatricians don't go to the hospital anymore. They might be hospitalists that are there. So you need to find out about, you know, if you were to get sick, where you go, and who might you see, and how might that information get back to your primary care physician. And the primary care physician is usually the gateway to the specialist, and they'll give you an idea as to who they rely on. And again, that relationship becomes, if they refer a patient to a specialist, how that patient is treated by the specialist and the feedback that the primary care physician gets from that specialist. So it becomes important for you to find out how the communication goes, how quickly people will get back to you. The last thing you want to do is to want to get in touch with the physician and not be able to get them. Many of them have services, and they will tell you who's on call and how that works. But you should have a fairly good understanding so that there are no surprises even when you have a physician you have the need. Your ability to get in touch with them or someone from the group, and how quickly they get back to you, and the instructions that they give you in terms of what to do.
Right. Excellent. Anyone else have opinion on this? This particular
I could certainly give an opinion, but to follow the really excellent discourse given just now is a little more difficult, because Kendall has attacked and spoken about the aspects that I would, and I'm sure most of us would want to mention. I will, however, mention that there are two components to your choosing the physician. One is a proper evaluation of the physician to be sure that you'll be able to provide what you want, and you look at experience and look at qualifications. And certainly the other is the way you develop the relationship with the physician, and to be sure that you are compatible with that particular physician. And that may be determined many things, social aspects, et cetera, even race, of course, to some extent. Let me mention one of the conflicts that I've seen. One of the most brilliant physicians I have known, in fact, one of my teachers in cardiology, excellent. I suppose one of the few geniuses that I've met. Yet his bedside manner was such that he could not attract patients easily. His patients saw him under other circumstances rather than coming on their own. And he was well known for his excellence in terms of knowledge, but not well known for his communication to patients. So I think that to establish a good relationship requires both components. You should see, experience, and have both those components. I'll say that from my viewpoint, however, maybe more than 50% of my patients are referred by an internist or a primary physician, sometimes from other specialists, but predominantly from primary physicians. And therefore, they come already with the blessing of that particular physician referred. They come with certain expectations and anticipations, so that half the job is done already when patients come to me, because they so trust the doctor who's referring them, for example, Dr. James Court. They so trust that doctor that they are willing to accept the information that I am prepared to give them. So that's a very important part in seeing a specialist, that you have the confidence of a good primary physician who refer you, and because of your confidence in him, you will therefore start off one leg up, start up ahead when you see that particular specialist. So I think those are some of the components in your choosing and sticking with a particular physician for whatever the illness is.
Yeah, excellent. Now, let me just stop just for a second. Dr. Kevin Clark came in. Kevin, can you introduce yourself, please?
Sure. Dr. Kevin Clark. I'm a surgical oncologist at the Newark Beth Israel. Sorry I'm late.
Oh,
I
no
kind of missed the first part.
Hey, Omar.
Yes.
One other thing that Trevor raised, and that's experience. And I think that's particularly important when you are going to physicians that either do surgery or do procedures, because their experience is going to be usually related to where they are in the practice, how many things or procedures that they've done, or particular types of procedures that they've done. You don't want to be going to someone who doesn't have a lot of experience in doing something. And that becomes important, not so much in urban areas where there's a lot of physicians, but when you start to get in areas that aren't so heavily populated, you might have individuals that don't see a lot, and therefore they don't experience a lot. You know, there are a lot of diseases or disorders where their occurrence is not so frequent, and then the physicians won't be so experienced in dealing with certain kinds of things. And so it becomes important to look at their experience, especially when it comes to procedures and different types of surgeries. And there are some complex surgeries. I know Patrick and Kevin can tell you about some of those types of things. You don't want someone that's seeing something for the first time. And if they are seeing it for the first time, we'll let you know, and we'll get additional help, or might refer you to someone who's a little more experienced in doing it. Some physicians have difficulty saying that they can't do some things. And so if you have something that is not so common, you need to be very careful about their experience in that particular area.
Mm-hmm. Yes, I agree. You know, Dr. Waldron, you're an ER physician, and I know you have patients that come in and they may not have a doctor. And you're the doctor who's seeing this patient and taking care of them, and you're going to refer them off, to a doctor. Or how do you handle it in the ER as far as referring patients off, or trying to make sure that patient is with the right particular physician, or a physician that is going to be caring? Mm-hmm.
Okay, so our ability to refer patients to a physician is restricted.
Okay.
And it is restricted by the rules of the hospital. So on a typical day, if I'm discharging a patient, for example, and the patient needs a gastroenterologist, I look at the call schedule, see who's the physician that's covering the service, and with great fidelity, I automatically refer that patient to that specific physician. Okay, if you ask me outside the context of the hospital, if I'm walking down the hallway, which typically happens, and a patient asks me who I would refer them to, then I'm at liberty to express myself and express my feelings. And I have to admit that that may be radically different from what is actually on the hospital roster. I would be in agreement with both opinions, so from both physicians who expressed themselves so far. There's not a lot of difference. However, I would like to emphasize one or two points. I'm not afraid to be a little bit controversial. I've spent a bit of time in public health, and there are very strong socio and cultural aspects of medical care that is important and is pertinent to race. And Dr. Atherley did mention that to some extent. I'd like to expound on it a little bit. I refer to a study that they did, that they discussed. It was San Diego, I think it was like 2 or 3 years ago. It was called the barbershop study. Essentially what they did, the physicians that were doing the study were Black. And what they wanted to do is to be able to get a sense of the type of experience that a patient would get from a diverse group of physicians. The physicians were recruited. The physicians were all aware that there's a study going on. The physicians were all aware that they were literally being watched because this is a study and they are under observation. Okay, so the patients recruited at the barbershop were sent to a diverse group of physicians, and they were treated over a period of months. And I'm going to tell you the finding that struck me as being the most important. And there were several findings, but the big take-home message was race concordance. And by race concordance, I mean Black physician, Black patients. Race discordance mean Black patient and different kinds of physician. The most dramatic take-home from that study was that when there was race concordance, Black patients got a lot more preventative care. In other words, their cholesterols were checked. They had follow-up for their kidneys, whether they did their colonoscopies, whether they were getting all the preventative care that was made. And I'm gonna just reiterate that the physicians knew that they were in a study. They knew very much that they were under observation. And yet this was the take-home point. Before I end, I just want to make a point that I have colleagues of all races, of all stripes, and they're excellent. And race should not be a basis for choosing a physician. You should do your homework. You should find out the experience, as mentioned by one doctor. You should find out the social and cultural habits, whether it's a patient has good bedside physicians. But there are different things that are reported in the literature. For example, there's such thing as called an empathy gap, that it is shown that physicians of similar culture tend to understand a little better and show some more empathy. So putting everything together, look at everything, including experience, look at the track record, what is the success rates, but then there are sociocultural aspects of care that you should consider.
Excellent.
Just one other thing, Omar, my wife is obstetrician gynecologist, retired. And there's been some interesting studies that sort of correlate with what Fred just said. You need to sort of look at the rate that women do C-sections for pregnancies, and look at whether or not people might be quick to remove a uterus that may not have to get removed. And so some of those things are also related to the concordance, or the other term that wasn't used, discordance between the race of the individuals. And so, yes, it could be related to whether or not you get preventive care, but also the type of care you get, or the decisions that might be made relative to the removal of the ability of a woman to have a baby, or whether or not they have a C-section, which might increase the risk of them having maternal mortality. So those things are also important for you to look at when you're choosing, especially women. And what it is well known that women are the major source of physician choice or decisions related to medical health care. And so it's important for the women in the audience to realize that they have an important role in not only choosing who their physician is, but their children's physicians, and often their husbands or significant others' physician.
All righty. Now I have 3 hands up, so I'm going to go in order, and we're going to let everybody speak. Patrick, please.
Yes, I agree just about with all the comments, with the understanding that we live in a time where we have more access to information, not necessarily the physician, but information about physicians than years ago. And I personally find that when a patient walks into my office, there are 2 sources of information. That of their point guard, which is usually their primary care physician, whom they know for a very long time, and the internet. Now, we all have bios on the internet, and I think looking in the mirror, we all should make sure that what's on the internet about each of us is accurate, because it's important information that patients use effectively before they walk through your doors. I find that patients, when they walk in, they not only rely on the opinion of the referring physician, but they also know more about me than I think they know about me. So I say to patients, there is the ability to do your homework. There's the ability to evaluate to some extent the background of physician choices. There is the ability to, even when you have to deal with specific specialties, physician experiences, where they're trained, number of years they've trained, And in most cases, and Kevin knows this, because we use a lot of high-tech equipment, our time spent on those equipments are logged and stored. That data is somewhere, and patients often has access to them. So I'd say to most patients, rely on your primary care physician. Ask some of those questions that, was mentioned by Dr. Sprague. Who would you see? Who would you send your wife to? If I was your sister, what approach would you take? Who would you send me to? And encourage them to use the information that they can access off the web.
Excellent. Dr. Salam, you're next.
Yes, this what I'm recommending might fall along the lines of common sense, but when I think of referrals for medical care or anything of value, any type of professional service, word of mouth could be very helpful, particularly amongst word of mouth from close friends and associates, people you trust. So to give an example, I'm originally from Newark, but left the Newark area a very long time ago. And so I relocated to the greater Philadelphia area, at least in New Jersey, the New Jersey portion of the greater Philadelphia area. And I was a little less familiar with this part of the state. And physician or not, if you want to take care of your health, you should have a primary care provider. And so my current primary care provider was recommended by a very close friend of my wife and mine. And she had been in the area for quite some time, and she really had a very positive experience with this primary care physician. And so I followed up on that recommendation, and it turned out to be a pretty good one. So that's always a starting point as well. And I've been with this primary care physician for quite some time. So I don't think as much data was publicly available, or perhaps I was just so positively influenced by my friend's recommendation. I followed up on it, and my experiences with this physician have mirrored hers. And so that's always a good thought, especially if these recommendations are coming from folks you trust. To piggyback on what Dr. Waldron was saying, I'm also familiar with some of that work because a close friend of mine, Dr. Owen Garrick, was involved in some of those racial concordance studies through a group called Bridge Clinical. And I think they were also, I think there was a Bridge Clinical, which is in the Bay Area of California, along with Stanford University. And to take it a step further, I think the greatest adherence with primary care recommendations came from doctors and patients where there was not only racial concordance, but also gender concordance. So Black men were more likely to adhere to primary care recommendations when those recommendations came from a Black male. And a lot of it has to do with trust and empathy. And so you would be a lot more reassured if your physician was viewing you as if when they saw you, they saw a member of their own family. And so it speaks to the ability of the physician to recognize the humanity in the patient that's sitting before them. And therefore, there might be a greater investment in outcomes. And speaking of outcomes, I think Omar spoke to this earlier. Dr. Omar Bey talked about the state of affairs among the number of Black males in medicine. It is an absolute crisis. And we want to address this crisis in the service of improved health within our community, because the literature this is a burgeoning literature, but it is a literature no less. You tend to get better outcomes when you have racial concordance between the physician
and the patient. So we all want better outcomes, particularly in the face of these healthcare disparities and health outcomes when you compare communities of color to white communities.
Excellent, excellent. I have a request here on when someone had typed in, could everyone please mute their mic? Because they're having, when we're speaking, then we're having echoes and reverb in the background. So whoever's speaking, just and I'll let you know if you're still on mute. But if we could mute ourselves, because there's an echo and a reverb back on the people who are listening. Dr. Court, you're next, please.
Good afternoon. I'm going to touch on the subject of critical shortage of physicians so that sometime in the future, we will see more of us in a panel like this. There is a shortage indeed, but in taking a survey of many of my patients, I usually ask them, do you know if when a person finishes medical school and they're doing their residency, do they get paid? Most of the patients says no, but in this era, people want to know that they're going to get paid. And it is not known throughout the country that we do get paid during our residency. And the other factor to me that discourages our population is the length of time. They think that 8 years is too long. And I sometimes tell them, how are you going to make a good living if you go to a course in 6 weeks? How? They don't understand that it takes time to be a professional. So I understand in order to be a professional attorney, you have to spend 7 years. To be a professional physician, it will take you 8 years. But after you've graduated, you do get paid. And I think, people want to know that they're going to get paid, so they don't want to, they don't know. And I think our purpose is, in terms of us on this panel and the audience, they should let people know that during your residency, you get paid. Okay.
Yes, thank you.
My other
go ahead. Go ahead, Dr. Clark.
In terms of choosing a physician, to me, the most important thing is how much time does that doctor spend with you? Is he 2 or 4 minutes, or he listens to you and answers all your questions, or he's just in a hurry to get out of his office and see another patient? That is very important. Many people think that the doctor is quick, that he's good. I don't. It's their opinion, but not too many people would share that opinion. And also, to me, the best recommendations that I have encountered is from the patients themselves. What experience they had with their primary physician or other specialists, it would tilt them in the terms of directing them to someone else who they would recommend if someone asked them for a doctor.
Excellent, excellent. Dr. Clark, you're next.
All right, I'll keep it simple. Sorry I missed the beginning.
No.
There are 2 things you need, competency and compassion. And I think that's the recipe for a good physician. Competency, I think, is self-explanatory. You have to have someone who knows what they're doing. They don't have to be the best or the number one in the world, but they have to have at least a minimum ability to take care of patients. And depending on what it is, specialties are a little bit different from a generalist in the sense that Dr. Spratt had mentioned it before. If you have pancreatic cancer, you don't want a general surgeon who doesn't have experience doing that procedure. You want somebody who's been trained and has extensive experience doing that particular operation. Another thing is you have to care about the patients, and you can tell patients can tell if their doctor cares about them or not. So that quickly becomes apparent. And what Dr. Court mentioned, your best referrals are your patients and other doctors. Because once they experience something, they'll tell you, you'll get feedback. So they'll come back to Dr. Court and they'll tell them, listen, please don't send me back to that physician. Or they'll say, listen, if I have other family members, can I also see this physician? So I think, to me, those are the most important aspects of choosing a physician.
Excellent, excellent. We have some questions, and And let's go through those before we go to the next topic. I've been a doctor. Excuse me. I've been to a doctor and that turned me off. He was very arrogant. I know he is educated, but it is important to relate to your patient and not to be too swift and leave the room or leave, the patient not really understanding. That's the number one. So I think if someone wanted to expand on this, that's fine. But I think we covered this in saying that, but I don't know if we did about taking time. And Kevin, you did mention this about taking time with your patients. I know from my practice, my patients are almost like family. I can't rush them out. If I tried to rush them out, they look at me strange. They're like, "What's wrong with you? You're rushing. You got
Right.
no place to go." I think, and also I think that a lot of physicians, of African descent, I mean, especially older physicians, I think we came through in a time when, well, put it this way, I came through in a time when Jim Crow was real. So I truly understand what people of African descent are going through on a daily basis. So when they come to me, it's more than I have blood pressure or I have diabetes. It can be anything. It can be, my son is like acting up in school. They give me some ideas, or it can be. It's more than just a physician. It's like they're looking at you for advice, for direction, and it's real. And you can't just rush that person out of your office, because I feel that's part of their medical, that's part of the medical, problem, is that, listen, if I rush you out, you're worrying about this so that it's going to affect your ability to function. Be it your diabetes is out of whack, or your high blood pressure is out of whack. Let's talk about something that let's talk about how we can, you know, treat you as your whole universe, your whole body, and move forward as far as that's concerned. Patrick, I know your hand is up. Go ahead, Patrick.
Yes, I want to make another comment. And this speaks to practitioners in general. Our license says to practice medicine and surgery, now not necessarily to practice gender-specific medicine or specialty-specific medicine. I think we all have basic knowledge, and I think it behooves all of us to be fair to our patients, in the sense that when we make a referral, we can look a patient in the eye and said, "Listen, I'm asking you to see Dr. Frederick Waldron because this is what I think." Okay. The other thing that I think we need to be honest about is, there is I think it was a furniture commercial that says, "My educated consumer is my best customer." And I think, when patients come to us, in order to do one of the following, either to instill a sense of confidence in them and hope they don't see it as being arrogant, but being genuine, and two, to make them comfortable by breaking that glass that suggests that we're physicians and we're so much more educated than they are, so they have to absolutely listen and follow our instructions, but to say to them, the education goes both ways. I'm here to educate you, and I need for you to learn about the specific issue at hand. That way, when I make a recommendation, whether it's my own treatment plan or my own decision to refer someone to someone else, to be confident in saying, this is what needs to be done. Should you decide to get a second opinion, you're more than likely will hear the same thing, but also encourage them, if you have question, in order to be comfortable with your decision, get a second opinion and be willing to provide the second opinion.
All right. Excellent. Excellent. Dr. Sprott, you have your hand up. You're muted, Dr. Sprott. You're muted. There you
Yeah,
go.
I started out by talking about insurances, and I think, I would be remiss if I didn't spend some time talking about the choices that individuals have about making selections with physicians and specialists. And a good number of our population has Medicaid or managed Medicaid as their insurer. And there are not the types of choices that one might have if one had a different form of insurance, because some physicians either don't accept Medicaid patients, or they might limit the number of appointments that they have, or they might limit the number of opportunities to perform surgeries if they actually accept some Medicaid patients. Because what the physicians get paid by patients that have Medicaid is less than what they get paid from Medicare, for example. And in certain states, the difference between Medicare and Medicaid can be substantial, as well as other commercial providers. And so, the ability for someone that have Medicaid to see a gastroenterologist or a urologist or another kind of specialist, even though they might have those physicians as part of a panel, their ability to see them quickly is not going to be there. And so one needs to be aware of these kinds of issues. And in some of the panels, they have physicians that are listed as seeing Medicaid patients, but may not be able to get appointments in a timely manner, especially if you have something that's serious. And for certain things like colonoscopies or other types of procedures, the ability for you to get that in a timely manner or when you should may also be restricted because of the choices that you have. And in some situations, those individuals, those physicians that might see Medicaid patients might limit dramatically the amount of time that they see them. And so you'll see that a lot of physicians in group practices, you have a certain amount of time that you have to get seen. And if you exceed that time, they'll ask you to come back and see to have another appointment. But a lot of physicians now are on the clock, and they are evaluated in terms of the number of patients that they see within the allotted times that they've been given for appointments. And so you just need to make sure that when you have physicians and you see how long it takes for you to get seen, or how long it might take for you to get seen, are things that are very, very important.
Excellent, excellent. Dr. Clark, please. You're
So-
on mute. Unmute. All right.
Just to follow up, and here's where I definitely don't envy the internal med folks or the journalists. Patients can come in and have a million different problems to talk about. Fortunately for us, it's usually pretty specific to one particular aspect. And even though that's the fact, sometimes patients, it takes 15 minutes and sometimes it takes an hour. And it's hard to predict a lot of times what situation you're going to get into once you get into the room. Dr. Sprott's 100% correct. We are limited by time, so you can't see everybody. You can't take an hour to see everybody when you have 30 patients in the waiting room. But I think to some degree, you kind of have to tailor it as much as you can to what's going on in front of you. Some patients you can kind of, I won't say cut it short, but bring them back and reevaluate at a later date. And some patients you just kind of have to stick it out and spend an hour and make everybody else wait. That's sometimes you just have to do that.
Yeah, excellent, excellent.
Excellent.
All right, Dr. Waldron, you're third on the list. Hold your question. Don't forget your question now. I mean, your statement. Before we do that, Dr. Aluya, you would come on. Can you introduce yourself, please? You're muted.
Yes, sorry, I came in late. Good afternoon, everybody. It's always a pleasure to virtually see all my brothers and senior colleague and mentors and everybody else as well. I'm Dr. Nelson Aluya, medicine pediatrics trained. I had to put the pediatrics on. Otherwise, Dr. Sprott will remind me. I call myself a medical advocate now. Presently in private practice, medical director, Sinai, I'm a medical director here and that, but the primary aim of what I do is to advocate on the health issues of our people and to ensure that they have access to adequate health, they understand the value of what healthcare is, and take better care of themselves. It's a pleasure to be here as well, always.
Excellent, excellent. All righty. Dr. Salam, you're next. Then Dr. Patrick Anderson, then Dr. Waldron. Go ahead, Dr. Salam.
So I promise I'll be brief, but I'm going to follow up on something Dr. Court mentioned, which is a little surprising, but I'm sure it's true. Folks not knowing that as part of your medical training when you're in residency and fellowship that you actually get paid.
Yes.
I'm about to introduce a topic that many of my colleagues are not very comfortable with, but I think it is critically important amongst the young and those who are coming up behind us who will ultimately replace us. But I think it's useful for the young to know that after the tremendous sacrifices of medical training, that there are some rewards. And so, folks are not necessarily getting wealthy by going into medicine, but medicine by and large affords you a very comfortable lifestyle. And so I faced some challenges during my upbringing, and I was largely raised in Brick City, Newark, New Jersey. So I'm very familiar with that struggle. And I never really viewed myself as a tightly buttoned up corporate guy. So medicine was deeply appealing to me because I thought it would give me a modicum of freedom and liberation, and that I would be judged by my education, training, skills, and ability, and versus what some corporate boss had on their mind or had in their design for me. So I'm very pleased with my career, and despite its demands, I like to share with folks that I have a pretty awesome life outside the hospital. And my children's upbringing is much different from my own. And that's due in large part to some of the benefits of a medical career. So, the rewards are there, and the marathon is certainly worth it. So I just wish more young folks who look like us undertook this marathon. And you'll see, compared to your friends who didn't go into medicine, medicine could afford a very comfortable and reliable lifestyle where uh, you're not necessarily affected by recessions and economic downturns. And it could offer you a modicum of security that, perhaps some of us didn't have coming up. So I think that's just very important to mention. And it's something I don't shy away from, especially when I'm talking to young people.
Excellent.
Omar, real quick. You remember the time we had that webinar at Essex County College,
Yes.
where there were about 30 something women and 2 or 3 men,
Yes.
and they all did not know that, yes, you do get paid as a resident.
Right. You're right. True.
We did several years ago, we did a webinar. I don't remember what year it was.
Yeah, it was quite a few years. It was before COVID. Yes. And you're correct, Dr. Court. They did not. But we got paid as a resident.
I might quickly add, I knew people who were very concerned about educational debt. And during medical training, at some point, I know in the Commonwealth of Pennsylvania, I believe it's after 2 years of residency, so your intern year and your PGY 2 year, postgraduate year 2, and then you pass USMLE step 3, you can apply for your unrestricted medical license and your DEA number. Once you have those credentials, there are moonlighting opportunities available to you. And I know I took advantage of this when I was a resident because, we started our family during residency. And, when you have children, you want to make sure that they're fed and their needs are met. So, there are are ways to manage the finances, and certainly physicians are in a position to repay their debts, especially if you're financially responsible.
Right.
So
I did the
for
same
those
thing
who have
too.
those concerns.
Yeah, I think most of us did. I did the same
Same
thing
thing too.
too. I was
Yes,
moonlighting.
after you got your license, you could
Oh
work.
yeah, you go
Yes.
ahead and moonlight. Patrick,
Yes,
do you were next, Patrick. You're on mute, but did you have a question?
Yeah, I had a comment, but
You're
you know,
good?
Dr. Salam kind of brought it up and discussed it.
Okay.
But you know, while we're on the topic of choosing a physician, I think, you know, there are models that originated in the business community that often um, prevents us from engaging with patients the way we would like to. And that is, you know, the efficiency of that workflow. So patient comes in, the efficient registration, the efficiency of the staff, getting data from them, information from them that's useful to the provider. Then the efficiency of the provider addressing the issues, and then it culminates into how quickly does the visit takes. And to Kevin's point, there are situations that requires 15 minutes, and there are situation that requires 60 minutes. And I think it's important to say to patients, if we're going to establish a relationship and have a long-standing relationship, you know, I do reach out to you to have some understanding of, or have some patience with respect to how much time I will take. Because when it's your time, if you require 60 minutes, you will get 60 minutes. I don't ever want a patient to leave my office and feel like they came in with a list of 6 questions and only 1 question get answered or got asked at least. So it all comes down to how much we embrace the relationship. You know, when we see a patient, we're trying to establish a relationship. And what I say to medicine, and to put it in line with you know, some of the comments that Dr. Salam has made, what we're doing, we're establishing a relationship. And for me, one of the most important things about what we do is our ability to establish and maintain relationships. Because to me, that's one of the most influential factors in keeping patients compliant.
Right. Excellent. Dr. Waldron, you were next. I'm sorry
Thank
about
you.
taking so long getting to you.
Thank you, Dr. Bay. My comment is pretty much along the lines of Dr. Clark and my brother, Dr. Anderson. As Dr. Anderson mentioned, that it's an issue of relationship, establishing a doctor-patient relationship. And as anyone in the audience or even on the panel will tell you, something that is indispensable to a good relationship is communication. In my perspective as an ER physician, and even as a patient, I have found that if I go to a physician's office and they state very quickly and clearly that your appointment is at 5 o'clock. However, we have an extremely busy day, or we had an emergency, and I apologize, but you are going to have a delay of 15 minutes. We have the same situation in the ER. In fact, the greatest complaint in the ER is that it's basically the waiting time. I have found anecdotally, and even from general studies, that when you communicate to the patient that there is a situation and they explain the reason for the delay, and especially the length of the delay, they have a great capacity to understand and to empathize with you. I have found, for example, that there in the ER, even when patients are waiting for a long time, and in comes a stab wound, and we have to rush over, and they delay the wait time for an extra half an hour. Patient generally have the empathy, and they have the compassion for their other patients, and understand that if there's a situation that merits it, And as long as you explain it to them and treat them like a human, that they will understand and they will be less irate and far better able to understand and have a good doctor-patient experience once you come back to see them. I've also, from time to time, when in the ER, and there are sometimes when I have no more than 5 minutes, and yes, unfortunately, I have to look at my watch, but I say, I am sorry. We are really busy. We have some emergencies, and I will come back to you after, but I just need to get the basics for now. And I apologize for the short duration. There is a reason. I understand you deserve your own time. I will come back to you as soon as possible.
Excellent, excellent.
to-
Dr. Court, you're next, please.
It's in reference to the emergency room and Dr. Waldron. One of the things that the patients don't really understand when they go to the emergency room is, well, one, if you have blood tests drawn, they don't do your test alone. They have to wait till the centrifuge is full, right? And then they press a button and they run all 10 tests. The same thing should apply to x-rays. You have your x-rays that's done by the technician. He then develops it and takes it to the reading room. And then he puts it at the bottom of the stack that the radiologist has. So the man doesn't have to come every 2 minutes to read one film. So you have to wait. One of the things that would educate the patients is they have to wait until all of those things are done. So it takes time. So if you notify them as soon as they come in, that when they have blood work done, they don't do their test alone. You have to wait for others to fill that centrifuge. Also for the radiologist to read all the x-rays until they get to yours. So you have to wait. And I think it would make them, not as angry as they sometimes are.
Yeah. Patrick, your hand was up. You're on mute, Patrick. Unmute yourself.
I think just to lighten the mood a little bit and to pick on Dr. Court a lot, he's made some statement that's kind of reflect the era in which he came up, and it reflects what's going on. In today's environment, one of the things we have is really access to information. So patients are respect speed and alacrity as it relates to access to information. So, hey, Dad, we don't develop films anymore. So
the film still has to be read. The film still has to,
yes,
to be read.
but also now we're talking about AI. So no sooner than that person comes out of the scanner, they want to know that their coronary arteries are clean. They want to know that the ventricle is pumping, 100% if there's ever such a situation. So I think that some of the challenges that we face, and there are things that have been put in place to kind of improve the efficiency. So just the way in our office they can sign in from the parking lot, their cell phone. I'm sure there are emergency rooms that still have similar systems that patients register their demographics are there and their complaints are registered even before the charge nurse who would triage them have a sense as to why they're in the emergency room. And with respect to the emergency room, go into the emergency room for an emergency, not for something that requires a visit to your primary care office, physician's office, or using a virtual access to a physician. So, part of the struggle we have to deal with when it comes to choosing someone from the perspective of efficiency and moving along is, how effectively we're implementing some of these technological changes into our practices.
Yeah, excellent. The thing of it is that, and let me just let everybody know where we are in place of the webinar. It's halftime, so and Dr. Atherley, just hold on to your question because we're going to do our halftime and then we'll come back to you. Also, after that, I'd like to come in and talk about some of the things that the patient can do to come in and help the physician. To move things along, like you talked about, Patrick. If there's the ability to go online and put your information in prior to getting to the doctor, that helps so much. Or get your insurance up, or get things like that. So we'll talk about that as far as our second hour. Dr. Atherley, can you start us off and introduce yourself?
My name is Trevor Atherley. I'm an interventional cardiologist. I'm predominantly based at Newark Bethesda Medical Center.
All right, thank you. Dr. Sprott, please, everybody's on mute, so can you unmute just for now?
Yep. Kendall Sprott, retired pediatrician. I did most of my work in Newark at both behavioral and at the medical school. I did general pediatrics, inpatient pediatrics, and critical care pediatrics.
All right, thank you. Dr. Waldron, please.
Fred Waldron, I'm an emergency physician. And like I said before, I was trained in Newark, and I've spent most of my working years in Newark.
All right, excellent. Dr. Court, please.
James Court, internal medicine. I work primarily at Newark Baptist Medical Center.
Excellent. Dr. Clark.
Dr. Kevin Clark, I'm a surgical oncologist. I work at North Bethesda.
All righty. And Dr. Aluya.
Well, Nelson Aluya, medicine pediatrics trained, medical advocate, presently in New Jersey, and always glad to be here once again.
All right, thank you. Dr. Salam, you're muted.
Good afternoon, Dr. Kareem Salam here, board certified adult and child and adolescent psychiatrist. I practice in Philadelphia.
Excellent. And Dr. Patrick Anderson.
Yes, I'm Patrick Anderson. I'm a gynecologic oncologist. I take care of women's cancer, and I work primarily out of Newark Bethesda Medical Center.
All righty. And I'm Dr. Omar Bey, pulmonary critical care, subspecialty in nutrition, and just thankful that these brothers would give their time on a Saturday afternoon to educate our people. Thank you very much. Note that every second Saturday at 1 o'clock, we're here to answer your medical questions. So please come on to the Zoom, tell mother, brother, father, everyone, tell your church, congregation, tell your fraternity, tell everybody that we're here to answer their medical questions so that, we can just, do our thing as far as educating people of African descent. The most important thing I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you from a medical standpoint. All right. If you want to see our past webinars, please just go on to OBHealthy, hit the YouTube sign. All of our past webinars are there. So many medical topics. Please just take a look at them. And I'd like to thank OBHealthy for allowing us to bring this webinar to you so that we can do this every second Saturday. Okay. What I'd like to do is I'd like to talk about what can the patient do. For instance, come with a list of questions. I know how I am. When I walk into a doctor's office, and even though I'm a physician, there may be things that I want to ask him or talk about and stuff like that. Should I put questions together and things like that? So I'd like to tackle that part, as we go forward. But before we do that, I'd ask Dr. Atherley to hold on to his question. So Dr. Atherley, please, let's get you to address your question.
Yeah, and just a comment, not really a question, the relevance of which may be disseminated after the pause. But at the time, there was a question of the communication to patients and the explanations to patients. I think it's very important that we not only demonstrate the expertise to the patients, but we demonstrate understanding, allow them to communicate with us and communicate back with them in appropriate circumstances. I will mention, for example, that very often, because I am hospital-based in a sense, I have to run from my office patient down to see an emergency in the hospital. And it does make a significant difference if you have a patient waiting and then you leave them with an explanation that you have to deal with an emergency and come back. When you come back, the patient is less likely to be frustrated and annoyed and upset. In fact, many of my patients will say, well, we understand, doctor, how did your patient do? Is the patient all right? That kind of understanding when you have to leave them and do something else in the interim. So I mentioned that just in answer to one of the comments that we made earlier. Communication, proper communication, and explanation to the patients with things they deserve to know.
Excellent, excellent. Dr. Clark, please, you're muted.
Sure. And you had started mentioning it, Omar. I think not only have questions when you're coming to the physician, but in preparation, understand why it is you're there. One of the most frustrating things that we have is patients coming in and they say, I'm here because my doctor sent me here. I mean, I think if you come in with some idea of why it is you're there and what the issues and problems are, that can save a lot of time.
Right. Just bear with me just for a second. I hear you guys, but my Am I on? Did I click out? All righty. I'm still here, but for some reason, my vision of the webinar is there. I am. I'm sorry. I clicked something and didn't know where I was there for a minute. Excuse me. I'm sorry. My technical skills are not as sharp as they should be, but we're getting there. All right. Excellent. Excellent. There's something that I would like to also say is our seniors. Let's just talk about seniors just for a minute. And I'm going to get back to Dr. Aluya as well as Dr. Salam, but I just want to bring up as far as our seniors are concerned, you know, I think, as people of African descent, we're so respectful, you know, and when seniors are attached to a particular physician, even if that physician is not doing the best for that person, they will stick with that person. And I feel that you should never be, unsure whether you should look to see if you can find a better doctor. Maybe I should put it that way. Trying to put it as gentle as I can. But the thing of it is never be, I got to stay with this doctor because he's been my doctor for 20 years. And it's so obvious that he's giving you subpar medical care to someone else, but you stay with them anyway, just because you've been with them for a long time. I think that, and maybe I should just put it out there. We should go with this thought just for a minute. And Dr. Aluya and Dr. Salam, hold on, and Kevin, hold on to your ideas. But let's talk about this because this is so important to me about our seniors, because I think they're such an attachment that sometimes the attachment, should be.
I'm going to interject, Omar, just real quick, because it's along the same lines. It's and
Go
not
ahead,
just
Kevin.
seniors. It's when should, and this is both from the perspective of the patient and the physician, when should a transition of care happen between a generalist and a specialist? So you come in with cardiac issues or diabetes or pulmonary issues, all of which can be managed by a generalist. But at what point should that transition be made? And what responsibility does the physician have to the patient to make that transition, and also the patient?
Right. And that's excellent. Are there others that may have opinions on this as far as, choosing an appropriate physician and then making sure that that physician is doing what they need to do, but also don't be afraid to change your physician if you feel that you're not being taken care of for whatever reason. If the physician's getting older, or if the physician's, the personalities don't fit, or whatever reason, and don't be afraid to change. Go ahead, Dr. Waldron. I just want to get this out there.
Yeah, I think you made a very, very important point. From the emergency department, I see this a lot. And it does not only pertain to elderly patients, it's across a wide spectrum of patients. And I'll give you an example. And this was not at Newark, Beth. I was actually at another hospital. And there came a patient with the kidney function test indicated that there was some ongoing renal failure. And the recommendation of the patient's nephrologist was that they need to be on dialysis. I look at the numbers and I couldn't disagree more. And what did I do? I called a colleague, Dr. Simon, who's not on this call today, but Dr. Simon is a Black nephrologist. And I called him and I discussed the case and I said, I'm very uncomfortable with this, that, this is the recommendation from one physician, but I do not believe that this patient should be on dialysis as of now. The patient subsequently followed up with Dr. Simon, and this patient thinks of me now as an angel. In fact, you should think of Dr. Sigmund Simon as the angel, because he's the one that really took on the care of the patient. And I have to say today that the patient is not on dialysis. And this is like 3 or 4 years later. So yes, I think we will, during the course of our training and our practice, that we will see cases where, whether the elderly or otherwise, that we consider the care to be substandard. It's not meeting the standard of care. And I think, especially when there is maybe a challenge to health literacy, that we are obligated to inform the patient that, well, I think there could be some changes. And I've done it. I've said, when you go back to your doctor, ask them if they could change your blood pressure medicine, because there are some medicines, given your diabetes, that it would slow down the decline of your kidneys. So I think we should be very, very comfortable with this subject. And I don't consider that I'm undermining one physician, because who is the prime client here? It's all about the patient, and our obligation is not for blind allegiance, but it is to make sure that our patient gets the best possible care. And even if we have to make suggestions, then we should.
Excellent, excellent.
Omar, it's Patrick. I have to apologize. I have to make a premature exit because I have another obligation. So, but to the panel, continue on. I mean, this is great. I think it addresses some of the potential perception that we have, that we can offer patients enough education so they make the right choices. And once again, I apologize. I'll see you next month.
All right. Take care, Patrick. All righty. Dr. Aluya, please.
Yes, so thank you so much. Well, I think we had talked about something like this before, maybe just before during COVID or sometime like this, preparing for a doctor's visit. I've always said it should look like you going to church, meaning you have to get yourself ready. You cross all your T's, dot all your I's. And what does that mean? Meaning, first, you have to look nice, dress well, because again, perception really does matter. Put on real comfortable, good-looking clothes, and so that when you approach the front desk, if the people at the front desk don't particularly look like you, then there's an issue of respect and regard, because that's where the whole thing starts from. Those are the front desk. They can make or break the meeting you have with your doctor, period. And most doctors, when they have bad reviews, a lot of them are usually not the doctor themselves. It's usually with reference to the front desk people, how they were perceived, how they were received, how they spoke to them, all of that. So it's a two-way stream. How you look when you enter a place determines. Look, people have the perception, they have their ideas, they have their biases, implicit or explicit. They do have that. But one of the things you must do as an individual, especially a person of color, to help reduce the propensity towards the bias. So when you come, of course, you have all your things that you have ready, your insurance, because sometimes they may have changed or something may have happened. But as the word patient, you have to learn to be patient as well when you come in. Be polite. Hey, how are you? I'm here for my doctor's visit. And you present, you wait for the question. Sometimes some of the front desk people might already know you. They have a relationship. It's fine. But if they don't, then they'll ask you, oh, do you have your insurance? Can I confirm your insurance with your ID? Because you don't know what that front desk person had just dealt with, before you, or even yesterday or last week. Maybe somebody came with a insurance that was fake and not, with an ID. You understand? So you don't know all of those. So sometimes some of us get angry or, really pissed off when they ask for an ID for your insurance. What do you mean? I was here last week and all that. Things change. And sometimes you'll be shocked that your insurance that was working yesterday, today is no longer working for some reason. And you may not even know it. Or they sent you a new card and you never saw the card. So All of those things really matter right at the front desk itself, because it can break or make a doctor's visit. And now when you're done with that, then of course you'll be polite, and you expect to be treated politely and with respect as well. And then you sit, um, you wait for your visit, and depending on what kind of relationship that and the establishment that they have in that place. Knowing now that we live in the era of AI, some offices are so much more advanced and some are not that advanced. And we get to a point where a lot of the time people have their information in their labs, on their phone. They have their what do you call it, doctors, what do you call it, ID, and they can log on to see everything that they need to see. Bearing in mind that as well, you can be taken to go do your vitals, and that's where the apprehension usually starts. A lot of the times, you're sitting down, they take the blood pressure really high because either you're anxious or either you're in pain or something else is going on. And at that point in time, whoever is taking that vitals from you, again, it's a mutual respect and mutual relationship. You have to be patient, follow the instructions, how they tell you. Could you sit down here? Could you stand up here? Could you do this? Could you do that? It makes or break a difference. That point of taking your vitals alone. And that can also alter what your vitals report would look like, so that by the time the doctor comes to see you, one of the first things they would ask and look at is the vitals. Your blood pressure is high. If they know you, then they may ask, hey, your pressure is high today. Why is it high? Or maybe it's just a white coat syndrome because you're anxious or you're in pain. And it's left for the doctor at that point in time to determine what that is. Now, the encounter itself, again, it's a two-way stream. You come into the room, they ask you to sit. Maybe the doctor, they talked about that. Maybe he's busy one or two or three other people before you, and then they have to come in. And most doctors, ideally, as soon as you come into the room, first you come with a smile. That makes a whole lot of difference, because one of the things that really does bother people is your doctor looks more angry and anxious than you are who's coming to see him. Or he looks even scroggy or doesn't look well kept, as a matter of fact, as well. And people regard these things. They see these things and they make impressions. And if you come in and you're late, you have to apologize. Oh, Mrs. Smith, I'm sorry. I came in late, or I had to do one or two things. How can I help you today? And that you have to have an open-ended question. How can I help you today? What's the reason for your visit today? And you just let them talk. And patients, when you allow them talk, feel satisfied that you're going to listen. And a doctor's encounter, it's an art. You have to learn the process. And as Dr. Spratt and some of you who work with residents, you already know these are some of the things you have to teach these young doctors coming up. A lot of the time, doctors are seen as egoistic, and if you push the level a little longer or push the button a little further, it becomes from egoistic to narcissism. And there's a thin line between that. And whoever is reading that, it's a subjective feeling. That may not be who the person is, but it's a subjective feeling and subjective assessment. But as professionals, as we expect the policemen to know how to handle guns or how to de-escalate issues, as professionals, we ought to learn how to do that as well. You come into the room, the patient is pissed off, they already have an angry face, you know that, and there's something wrong. Either they're in pain or something's really bothering them. It's left for them to say, you know what, I need to learn to de-escalate this. And then you find a way of keeping, even if you're boiling in the inside, and you know this is a patient who comes in so often. He came in last week, asking for dust. At that point in time, you just have to hold your breath, hold it still, and let your temperature and your blood pressure go stable. And then you have to listen and let them talk. And of course, we're so pressured with time. In between doing that, you open up your laptop or computer. Don't back the patient. Let your computer be set up in such a way that at least when the patient is talking, even when you're typing, you can hear them. And from time to time, turn towards them. Let them talk. But you can be preparing your own stuff, looking at results and everything that you're doing. in the process of them talking. Now, all through that, you have to learn how to interject without being rude as well. Because once they're talking, and some people will just talk and talk and talk, just keep talking. But you just have to learn how to interject, just flow in quietly and like, oh, okay, miss, I hear you. You have to acknowledge what they're saying. I hear you talking about your pain. However, where is this pain? Let me tell you, I have a pain. And the pain started 2 weeks ago. And it started because, I rode the bike and I fell. And then you find that they go in tangential. You have to find a way of rolling them back in and coming back to a point. Where's the pain? How often do you have the pain? What makes it worse? What makes it better? So that you can understand the process. And
Right.
then, as much as possible, have to have control of that discussion, not out of dominating it, but at a point of a conversation, you guys understanding one another where the process is. Because at that point in time, he or she has an expectation of what she or she wants. And you also have an expectation of what you want and how you want to have it processed. So these are some of the early things of how to do that. Now, on the patient side, I've always said, look, write down some of the things that bothers you the most. In a scale of 1 to 10, the one that is most, you put at the top. Those are the ones you begin to discuss first. If it's pain, if it's a headache, if you can't sleep properly, before you go down to discussing other stuff. And that is one of the first steps of helping people understanding that, a doctor's visit can be very, very engaging, can be very satisfying if both sides have an expectation of what they want, how to achieve that.
Excellent, excellent. Now, we have Dr. Ali. It just came in. Dr. Ali, introduce yourself. This is our California edition here.
Hi there. Good morning from the West Coast. Sorry for my delay. I'm at a conference, so I was a little delayed this morning. But my name is Dr. Mazhar Ali. I'm a gastroenterologist at Scripps Clinic in San Diego, California. Thank you for having me.
We're always appreciative, even if you can just give us a few minutes, Dr. Ali. Anytime, you sign right on in.
No, it's a privilege to be here.
Right out. Dr. Salam, you're up.
So really quickly, I'll try to be brief. Thank you, Dr. Aluya, for that very comprehensive approach to preparing for the doctor's visit. A quick thing I'd like to add is the doctor's visit is actually an excellent opportunity to make good and productive use of the smartphone. So I know when I visit my primary, I record my vitals, and I guess among physicians, I'm probably not necessarily a technophile, but I'm not an early adopter of technology, and I use the technology that I have to when I'm forced to. But for example, your primary, let's say you're not logged into these different portals where you could access your labs quickly, you could ask to take a screenshot of your labs when you visit your primary. And the advantage of doing those things is all that data is collected in your phone, the notes section of your smartphone, and you're able to kind of review trends over time. So it helps you become more an effective healthcare consumer. As Dr. Aluya mentioned, you may have many questions, but you want to document all the questions you have, but you want to rank order them in terms of importance, because you won't get to every question during that visit, but at least you will leave that visit armed with information because your top 3 were addressed. Finally, in terms of healthcare, as doctors, society has conferred this lofty position on us, and it comes with very great responsibility. However, when you receive healthcare, you are a client, you are a consumer, and it really helps to advocate. And I think one of the most important pearls of wisdom I would like to share with consumers of healthcare is ask the doctor to explain things in simple terminology. So I think I recently heard a running joke is, if you want to appear smarter than you actually are, throw around some terms in a different language, whether it be Latin or French, and then people, you know, they bless you with extra IQ points you don't really deserve. Well, in the setting of a doctor-patient encounter, you have every right to ask the doctor to explain things in plain language and avoid the medical jargon so that you're there to understand and to be understood. And so in order to achieve that, you have to speak the same language. And we all need a reminder that we're not speaking to our colleagues. We're speaking to the people that we serve, and we want to do so in very clear language.
Excellent, excellent. What we have is two hands up. Dr. Sprout was first, and Dr. Waldron, you'll be second. Okay, Dr. Sprout. And understand also we have a few questions that we want to get to before the webinar is ended. Dr. Sprout, you're up. You're on mute, Dr. Sprout. You're on mute.
I think that you started out by talking about seniors, and I think a lot of seniors are not so technologically advanced. And you know, I've served as a go-between between a lot of my friends and relatives with other physicians, and have to help them navigate patient portals in order to get information so that, you know, I can help advise them on what's going on and what may or may not be needed. And so I think it is important that if individuals are not aware of the access to information, if indeed their docs have patient portals, to get their younger, either children or people that are more technologically savvy, to help them navigate. And then, you know, there are lots of things where if they are unaware about how to use it, that their communications from physicians is there. The doctor's trying to explain to them what some of the lab results have been, or some of the radiologic diagnostic tests have been, and they're not aware of it, so they don't know that they can communicate and get back to them. So if they have relatives or friends that can help them navigate and interact, then they can get a lot more information from the doctor and learn a lot more. And maybe before they even get there, ask questions that the doctor can then be prepared to answer. The other thing I wanted to touch on was, you mentioned about, and Dr. Waldron, I think you might have mentioned standard of care. So when you mention standard of care, that touches on the issue of medical malpractice, because there's a standard of care that's not been met, that might cause harm, that might be leading to some kind of litigation. And I know that I've done critical care. You've been in the emergency room. Some of the specialists have gotten referrals from individuals where there were missed opportunities in terms of either diagnostic work that was done, not followed up specifically as it should have been, or, you know, in intensive care train wrecks that come in because people didn't do what they could have done at a much earlier point in time. And certainly I've seen friends that have had significant issues related to problems post-op that weren't managed appropriately. And what I fail to understand sometimes is, number one, how a physician could not take care of a problem of an infectious nature. And then the issue of the friend being somewhat afraid to ask about whether or not ID or wound specialist could get involved, or even leaving to go to another physician for a second opinion. You know, some of the things that were said was, you know, I don't know if I go to another physician, they all know each other, and the town isn't but so big, and I won't get the kind of care that I need. And I said, well, go out of town. You know, you got the ability to even leave town. But I think that there's a certain, I don't know if I don't think it's just loyalty. I think it's just, there may be a fear factor of they might not even get better care if they leave a doctor who's obviously not done what they should have, to their detriment. And so I think that when people realize that the care that they're getting isn't what it should have been, they need to be open to other possibilities in terms of physicians or that they can get referral from. And they should go back if they have a primary doctor to go to their primary doctor. But they, if you've been referred to a specialist from a primary doctor and that person isn't providing you with the care, either the doctor will know about it, or if they do know about it, they won't do it again and may offer you another physician that you can see. But you need to be open to communication with the primary doctor or to another doctor of the same specialty, because the person who's most responsible for your health is you. And if you've not gotten something right. You talk about common sense. If something's wrong and it needs to get taken care of, and it's not being taken care of appropriately, to do something different.
Yeah, excellent, excellent. Dr. Waldron, you're next. You're on mute, Dr. Waldron.
I'd like to add to what Dr. Sprott just said. And it is in reference to the patient's ability to interact or to be part of the decision-making in his or her own care. I'd like to speak directly to the participants that I believe that you should have a very healthy skepticism. Doctors are given great respect for their knowledge, and appropriately so, but we are not infallible. You should, especially whenever there is a decision point where there are multiple types of management, the doctor usually is very good at explaining that one choice, explaining the choices, and inadvertently will make a decision on one choice. If you are uncomfortable with it, you should feel comfortable in getting a second opinion. We are not infallible, and mistakes do happen, and sometimes it's not mistake. And I'm not talking about the case where one doctor prescribes you with one type of antibiotic, maybe Levaquin, and another doctor prescribes you Augmentin. I'm talking about a choice where it's surgery versus no surgery, or a medical management along a certain line. So yes, the educated consumer and the consumer who examines the choices, and if you are unclear about it, you should be comfortable enough to get a second opinion.
Excellent, excellent. Dr. Ali, yeah, your hand's up. You're on mute, Dr. Ali.
So just to piggyback on what Dr. Salam had said, as well as Dr. Waldron, I take care of, as a gastroenterologist, I take care of some patients with pretty complex disease states, such as like Crohn's or ulcerative colitis. These patients require biologic therapies. They may involve surgery. I would want to say as well, to piggyback on what everyone else said here too, if you see a doctor and you don't feel comfortable, or you're just not getting the explanation that you deserve, and you want to seek out second opinion, you're completely entitled to it. But if at any point you feel in any way slighted by that doctor because you're going to seek a second opinion, that's a red flag, right? We as physicians, one of the biggest virtues that, and characters that we should all have is humility. And if you have a doctor that's not demonstrating that humility and that humbleness, that means that you should seek that second opinion and get the information that you need. You should never feel bad about that. I actually encourage my patients to seek second opinions, because maybe there's something that I'm missing. Maybe there's something that I want to get another perspective. Maybe I'm not looking at all of the pieces in the right way, and that's okay. It's okay to admit that you may be missing something here. I think, we're human, we do the best we can, and we use the best available evidence that we have. But I would encourage it. And you should have a physician that would encourage it as well.
And that's so appropriate. I tell my patients all the time, their bodies did not read the textbook. And just because they're coming to me with a problem that I may not be able to put together doesn't mean that a second opinion, another pulmonologist, another critical care guy may have a different, he may be looking at the elephant from another angle than I looked at it. And because, and I also tell my patients this too. If you go to a doctor and he feels he knows everything, guess what? You need another doctor, because there are doctors out there that feel that they're, the last word and they know everything. And how dare this doctor say this and he doesn't know? You need another doctor, because medicine is too wide, too broad, and too complicated and intricate at this point in time for us to say that we know everything. That's true. I want to get to some of these questions before the time is gone. Let me just read through them and we can comment on them quickly, because we have about 4 or 5 of them. It is true what Dr. Anderson said. I look up a doctor on the internet to see how his credentials was. Is it important to know this? No, his or her experience, education, and length of time. So this is something that this particular patient does. Prior to going to the doctor, they use Google and say, hey, what is it, 5 stars, 2 stars, or 1 star? How important is that? Can somebody comment on that, as far as, what we have at our fingertips these days? It's different than when I started, that's for sure. Somebody want to just chime in? Dr. Ali, you're a youngster. You have a thought on this one?
Yeah, so reviews can be helpful for in any situation for consumers, right? We need a service for our house. We want to look at a restaurant and figure out what's going to work well. You look at those reviews. I do it all the time. When it comes to medical care, though, I think there's some caution that you have to weigh in, because again, we're not treating in a cookie cutter setting. Everything is very individualized, and every situation is very different in terms of what somebody's coming in for. I often have patients who come in and they may have one agenda where they would want something specific, but I would know, based on kind of seeing the clinical scenario, it may not be the best option for them, and they may not agree with me, and that's okay. We can agree to disagree, but ultimately what we want to do, as well as be good stewards of making sure we're providing the best care possible. So that may be different than maybe the expectation, and that may translate to maybe a poor review or something that we're not meeting that expectation. So I think that we would have to really look at that with a little bit more of a grain of salt. If you see consistent bad reviews, then that may give you a little bit more of a clue. But I wouldn't use just one isolated event, because again, everybody's so different.
Yeah, true. And as Dr. Patrick Anderson, I think, said earlier, make sure that what's on the internet is true about what you do and who you are and how your practice goes and what you've done in the past. That's a problem as well. There's another question here.
I
I'm
think
sorry.
if I may add to that,
Yeah.
and as doctors
And
too,
let's keep it short, Doc, because
right, and as doctors too, you have to go online sometimes to review what people are writing about you, because a lot of these times they may not truly be true. You understand? And because what they see on the outside, may reflect you, but they may not actually be true. And there are areas or avenues where you can, either reply to that or have ways of taking them down. And medicine is changing so quickly. There's what they call consumer experience engines, where AI is going to come into the play, and they would begin to decipher how and perception that people have about you. That's another topic. We can talk about that later. Maybe we'll go through some of those questions.
Yeah, I think AI is going to change what we do and how we do it in dramatic ways. I truly do. And we'll see how it all plays out, but it's going to change dramatically how medicine is practiced and what doctors are able to do and how they do it, I think, truly. There's another question here. How do I handle the disconnect between my rehabilitation facility and my primary care doctor? Also, the radiology facility and my primary care doctor. Facilities that do not update my doctor. This is a problem. Because if you're in a and we can and we I'm sure we all experience this. We have a patient that comes out of the hospital, goes to a rehab facility, but you may not go to that facility, and somebody else may be taking care of your patient. And when the patient got there, they have no idea who this doctor is, what's going on, you know. So give us some idea on experiences that you physicians have found, and how we can help this patient at least understand what what's involved, and when you go into a facility, and the relationship you may have with the doctor. If it's not if that doctor's not on staff, you have to be on staff. If somebody can start this out. Dr. Sprout, you have your hand up. You're on mute, Dr. Sprout. Please unmute.
This goes to one of the things that you talked about earlier, and that is a rehab hospital.
Mhm.
People sort of need to understand that a rehab hospital deals with rehabilitation. That means that an individual has had some kind of injury or some kind of a surgery, and they need some time to recover, to get rehabilitated, to go back to a semblance as to where they once were. And so rehabilitation means that there's going to be some expected improvement in the outcome of what's going to happen. That's different than someone that's going to a nursing home where you're talking about care, and you're not talking about rehabilitation or having some kind of improvement. And so what normally happens is if someone has, and it typically occurs with some kind of orthopedic issue where someone has a replacement of something, and they, now they're doing it such that you can have this done on an outpatient basis. But in some situations, it's no longer a need for you to be in an acute care hospital, where you then get transferred to a rehabilitation hospital before you eventually go home. And so people need to understand about what happens to an individual if they've had something, then they go to a rehab hospital. But the rehab hospital is usually managed by physicians that deal with rehabilitation. So there's physical medicine rehabilitation specialists that specialize in getting those patients from where they were when they left the acute care hospital to a point that they can go and be discharged. And the amount of time that it may take is going to vary depending upon what kind of injury and what kind of recovery time that they may have. And so that it's the physiatrists or the rehabilitation physical medicine specialists that ought to be communicating with the primary care doctor. And usually that's going to occur by the time that they're approaching a discharge. And so if it's an orthopedic surgeon that did the surgery, they did that, and then you need the recovery and rehabilitation where they have different kind of therapies. It could be physical therapy, or if you've had a stroke, occupational therapy. There may be a speech therapy. There may be a number of individuals that are involved in trying to get you back based upon what kind of procedure you had. And Kevin's there's some individuals that have cancer kind of therapy that may have injury to their swallowing mechanism. There are all sorts of things that can happen. And so it becomes important for those individuals to at least have some kind of communication before they're discharged, so that the primary care physician understands what they had, where they are, and what the expectations are in terms of whether or not they need to go back, whether or not they need to have physical therapy or some of these other therapies on an outpatient basis. Because in general, primary care docs are not involved in directing the various types of therapists that are involved in trying to get rehabilitated. And so the issue of that communication is incumbent upon that physical medicine rehabilitation specialist to communicate with the primary care. And the patient or the patient's family ought to be instructing that physician to communicate, to give them their information before they get discharged or they go back to home, and especially if they're going to have ongoing types of therapy. So I think the family or the individual ought to be able to request and make sure that that information transfer takes place.
All right, thank you. Thank you very much. We have several hands up. Dr. Ali, I think you were first.
Yeah, so just to address the issue where you go to a specialist or you may get an X-ray, you may go to a lab and it doesn't communicate through. Sometimes because of our hospital systems or medical system, they just don't communicate with each other. Certain primary care doctors' offices or specialist offices may not receive the fax for information. One of the things that I do suggest to all of my patients, particularly those that may not be technologically as savvy with certain things, is to keep a trapper keeper. Have a notebook, keep a trapper keeper. Because of our laws, you have every right to request and have records for your notes, for your lab reports, for your imaging studies. So I tell patients, get those reports, put them in your trapper keeper, put them in your notebook, and just keep a record of them. Or if you can get the file, put it into a PDF and keep it into a zip drive or some sort, because it does help if you're going from one place to another. You know, as a former military doc and I was a military patient, I would be stationed one place, I'd be stationed a different place, and unfortunately those systems don't communicate. So I used to have to bring this, but it turned into a very useful tool that I actually talk to all my patients about. And I find that could be a very helpful tool for any patient who needs to keep those records clear and everyone is on the same sheet of music.
Right. Excellent. Excellent. Dr. Aluya, please.
Yeah, with regards to what Dr. Mazza just talked about, again, it's part of preparing for your doctor's visit. You have to have a tracker, a folder sometimes, where you have all the things that has to do with your health. Just like you track your finances or track everything else, health is much about the most important thing as well. So you have to have a tracker for that, so that whenever something happens, you can refer to those. For instance, your doctor asks you to go do a blood work or CT scan or something. When you did it, where you did it, all of those things, because again, those centers ideally should fax the report to your doctor, but often enough they don't. And even when you leave the hospital, the day you leave the hospital, ER visits and everything else, you'll be shocked. Most hospitals don't get back to the primary doctor. They really don't. So having that tracker, so that when you sit with your doctor, it's always easy to discuss this. Now, for the patients, every time you go to the doctor or you get discharged from the hospital, please, within a week, set up an appointment to go follow up with your doctor. Have a discussion one-on-one. At that point in time, you're not coming to talk about your headache or whatever. Doc, I was in the ER, or I was, and Dr. Waldron will know that. A lot of times you see they give you a note, follow up with your primary care or follow up with a specialist. You have to set up those meetings and appoint, because that's one time where the doctor will also sit with you, look at your medical history, and reconcile your medication. There's a point where it's called medical reconciliation. What happens is the person who you saw in the ER or in the nursing home, I've been a medical director of a nursing home, 400 bed for a long time. And I see this all the time. When people go home, they don't connect back with their primary doctor. So once you do that, hospitals, ER, nursing home, set up a meeting within a week, maximum 2 weeks, sit down with your doctor, reconcile your medication, because they may have actually started you on a medication that your doctor, already had you on, or because of the prevailing things that's happening to you, will decide to review the medication and choose which one you should follow up with. It's always important to do that.
Excellent. Excellent. The thing of it is that, and I don't see any other hands up. I just want to talk about two things I wanted to talk. And Dr. Clark, he had to step away just for a minute. But number one, medical insurance. And I know that out in California, it's regions how medical insurance is. In one region may be a little different than another region of the country. But let's just for our seniors, and a lot of them who come to my office and they're turning 65. What do I do, doc? Now Medicare is coming about. How do I handle this? What is this Part A, Part B, Part C, Part D? Can we get an explanation, just a basic explanation of what this is all about? Can someone just put it in easy terms, and does anybody feel comfortable talking about that? If so, if not, I'll start it off. Well, the thing of it is that once we're seniors, we're offered Medicare. All righty. And Medicare to me is the golden card. That red, white, and blue card is the best thing ever. And from a physician's point of view, it's the best thing ever. Because number one, what it allows us to do is it allows us to see the patient. Number two, to get a fairly decent reimbursement. Not a great one, but a fairly decent reimbursement. So most physicians will accept Medicare with no problem. The other thing that it allows us to do as physicians is to schedule tests without pre-approval. So if I want to get a CAT scan of somebody's chest because I feel that they may have pneumonia or they're a smoker and they need a quick CAT scan to make sure that this cough that's ongoing is not something that may be cancer, or they coughed up blood, is it bronchitis or is it cancer? I can get a CAT scan without a referral. I can write that prescription, send them to the radiology area and get that CAT scan done. That's so important. Is there any other aspects of Medicare that we find that you find? I mean, I could keep talking, but I don't want to let you guys talk about. I want to let you guys talk about this because we all look at it differently. But I know from my practice, Medicare is very, very important. A lot of patients will get that umbrella coverage, and I think that is called Medicare C. Is that the Medicare C? And that umbrella coverage basically allows you to have have your insurance paid for, but also it does your prescriptions. But the thing of it is that what it does is you have to get approval for each procedure that you do. So if Dr. If Dr. Ali wants to do a colonoscopy, you have to get approval for that. If I want to do a CAT scan, you have to get approval. And there are times, believe me, that the insurance company says, well, in our algorithms or how we think about it, we're not going to approve that. So we're stuck as physicians. We would like to get it. The insurance company saying they won't approve it, and the patient has to bear that burden. That burden can be many thousands of dollars. Understand? So there's a good and a bad part, because a lot of patients will take that Part C because they say, well, I can't afford that 20%. What is it called? The 20%.
Copay.
That not the copay, but the
Deductible.
Deductible, yeah. I can't afford that deductible, or I can't afford to pay that extra for the prescription coverage. So it's a catch-22 before our patients. And it's very important that you understand that the best plan from my point of view, and this is the plan that I have the Medicare card, that red, white, and blue card. I have that 20% supplement, which you can buy a 20% supplement. And then I have a prescription plan that I buy. Now, understand, my eyeglasses is not covered. If you have hearing aids, they're not covered, that kind of stuff. But if you can afford it, keep your Medicare card, because that
It's your
allows
primary.
you to get, as your primary insurance. That allows you to be able to get tests, see doctors. I'd say probably 99% of doctors will accept a Medicare, that basic Medicare card. Dr. Salam, your hand is up.
So I'm going to quickly add on to this, but I'm going to talk about Medicaid.
Mm-hmm.
So I don't know if this is unique to Pennsylvania, but I don't think so. Something to keep in mind, especially with mental health. Medicaid is a government program that focuses on folks with lower incomes. So there tend to be income requirements. If you fall below a certain income, you qualify for Medicaid. But what I have observed is that there are some people who have primary insurance and they have secondary Medicaid. And what I have learned is that in some situations, Medicaid has more generous mental health benefits than primary insurance. Why might that be important? I take care of kids. I run an inpatient unit, and the kids who have Medicaid have access to an entire menu of mental health services that those with commercial or private insurance do not have access to. In addition, sometimes a kid may need to stay in the hospital for a longer amount of time than the private or commercial insurance is willing to pay. And if you have secondary Medicaid for that child, not necessarily for the family, but for that child, it might be an advantage. And again, in addition to the limited benefits offered through the commercial or private plan, if they have secondary Medicaid, they could have access to an entire menu of services they wouldn't otherwise have access to, including a greater length of stay in the hospital if their mental health issues are more severe and require that.
Mhm. Excellent. Excellent. Any other comments on this?
Well,
Yeah, I want to just comment a little bit about what Kareem talked about. So Medicaid is, as he talked about, is healthcare insurance for the poor, but it also is available for individuals that have developmental disabilities that their families may or may not be poor. And it also, I mean, you think about it in terms of healthcare insurance, but the largest expenditure of Medicaid is for long-term care, nursing home, which is something that Medicare doesn't pay for. So when you talk about Medicare, you know, the Part A Medicare was the primary thing that it pays for is for hospitalization. So if you have Medicare, you get and the other thing that's important, when you hit 65, you need to apply for it.
Right.
Okay. Please don't forget to apply for Medicare when you get to 65.
Because there's
not everyone does.
There's a time window.
Huh?
There's a time window in that.
Yeah, and you get penalized. So don't, when you hit 65, you need to apply for Medicare Part A, period. Whether or not you want to do any additional stuff, you may or may not want to do that. But the other thing is that, you know, very often it's Medicare. The other thing that as you get older is the issue of Social Security. And so you can have Medicare and some of in addition to the Medicare Part A, which pays for hospitalization, sort of this umbrella of things that might pay for lots of other things. But in general, that payment may come from your Social Security to pay for that supplement. And sometimes you can get it for nothing. And once you get 65, even individuals that have Medicaid will and should apply for Medicare. So the fact that you have Medicaid as a healthcare insurance, you hit 65, you still need to have apply for Medicare, and then you have dual Medicaid and Medicare. So a lot of people that you know have money may run into the issue of either their family member or themselves having to go into a nursing home, okay, or assisted living. And people need to understand that the government is interested in getting money back if they can. And so if you have money that's available and you need to go to a nursing home and you want to have it paid for by Medicaid, then they're going to want to get whatever assets you may have in order to pay for the cost of long-term care or nursing home. And so they look for, if people try to exhaust their assets before, they look back years to make sure that you didn't take money or shift money that they want. But for most people that are in nursing homes, a good portion of them, Medicaid foots the bill, Medicare does not. If that person that's in a nursing home has to go to a hospital to get surgery, then Medicare will pay for the surgery. And they will have different amount of days that Medicare will pay for hospitalization. but people need to sort of be looking into the issues of, as they get older, what they're going to need to do in terms of long-term care if they need it. Because long-term care, if you have money, is extremely, extremely expensive, especially if you want some decent long-term care. And we're talking about not what nursing homes do, because nursing homes pay for very little. The number of individuals or healthcare workers that they have taking care of patients the ratio is not very great. But indeed, if you can't afford it, then the resources that the individual has needs to get exhausted, and they then become eligible for Medicaid because of low income, and then they can get admitted to a nursing home. Sometimes they're waiting lists for these things, but it's not an easy thing for a lot of people to understand and to navigate. But a lot of people will want to have the kind of coverage that a supplement that takes care of the things that Medicare doesn't pay for, like eye exams or things like that. Some of the Medicare programs, and again, there are a number of, all the major insurance companies are involved in it because there's money to be made in it. And so you'll see that they will pay for your prescriptions, but they'll have, just like anything else, they'll have types of medications that won't cost you anything. And then they'll have the various tiers. The higher the tiers go, the more you have to pay as a deductible for those kinds of medications. So you see that some of the much more expensive medications and some of the medications that are associated with cancer and things that end in AB, the monoclonal antibody kinds of things that are extremely expensive, then those are not going to come without some cost for you. And then depending upon a drug and how much you spend, they're trying to. That's why this election is very, very important. I don't know, people are paying attention, but sometimes you'll fall into they call it the donut, the hole, where you end up having to pay a lot more money than you were typically paying for a certain amount of time because they have paid the maximum amount. So again, if you're looking at the various types of Medicare and insurance options that you have, you can see whether or not you just, you have the straight Medicare that pays for hospitalization and might pay for a certain amount. But more and more people are looking at these Type D Medicare, where it's an umbrella of services, including some related to dental work that Medicare has never paid for.
Excellent, excellent. We have two questions that we're going to end with. Let me get the first question here. What can be done when the insurance company confirms that the doctor was in network, but I was still sent a huge bill since the billing was done out of network? I don't quite understand the billing done out of network, but I do understand that there are times when you'll call and they'll say they're in network, and then you still get a bill. It sometimes, and if it was a procedure, there's a possibility that if it's at a hospital, the hospital may be in network, but the physician who took care of you may not be in network. The anesthesiologist may not have been in network. The doctor who did the surgery may not be in network. So it really breaks down to what part of the bill you got, the big bill for, and what aspect came through that way. It gets a little complicated as far as procedures and things like that. Who's in network? Because a lot of times you will ask the insurance company, "Oh, is this doctor in network?" And say, "Yeah, but the facility that he uses wasn't in network." It really gets a little complicated. Anybody else have an opinion on this?
So can I just give, it's a little complicated, but in general, hospitals have contracts with insurance companies. Almost all hospitals will accept both Medicaid and Medicare, but they may not accept the commercial or different kind of commercial insurance because of what they will or not come to an understanding about I'll say the per diem or the amount of money that the hospital can get from an insurance company on a day rate. So if someone comes to the hospital The bill for that visit, either an ED visit or whatever it is going to be extremely, extremely high. And part of the reason is that they have to charge everyone the same amount. The federal government requires that they can't be charged anything different than a commercial insurance. So that bill will be extremely high. You'll see these stories about, aspirin costing $100 or something like that. These charges are just that. They're charges. It doesn't mean that the hospital's going to get paid for charges. The hospital's going to get paid for an insurance company that's within their network and agreed upon contractual payment, and that's it. Now, the patient won't be paid anything other than what the commercial insurance pays unless they have a deductible associated with hospitalizations, and they may or they may not, okay? Typically, certain physicians at hospitals don't participate in being in an insurance network. I dare say Dr. Waldron and all of his ER compatriots don't accept insurance. Why? Because they can get paid a lot more money if they're not in network. Trauma orthopedic surgeons, some neurosurgeons won't accept some commercial insurance because they can get paid a lot more if they're out of network, especially if they come to the hospital via the emergency room. Because if someone comes to the emergency room and really have a real emergency, they have to get admitted, and the hospital will get paid a lot more money if an out-of-network patient comes, is admitted, and they have to pay charges, or if they can negotiate something. So there is often a disconnect between whether or not physicians are in network or physicians are not in network. Most of the physicians will usually be in network in hospitals where a lot of their patients have an insurance that they go to. But there may be a disconnect between individuals that don't participate in or in network with the insurance companies, even if the hospital is. And anesthesiologists, ED physicians, some trauma orthopedics are not in network, even though the hospital's in network. And so some of those folks, anesthesiologists, will get bills that the insurance is not going to pay. And so the patients will get stuck with that. And again, lots of complaints about this. And the government is trying to deal with some of this stuff, but there are vested interests by individuals and or hospitals even in trying to manipulate the system. In some situations, 90% of the revenue that a physician or hospital might get might come from out-of-network patients that come in. So there's a vested interest in trying to keep it that as it is, even though it's patently unfair.
Right. Let me just, we're going to end up right now, but let me end up with just this. And let me go through the Medicare because it can get a little complicated. Medicare Part A basically covers hospital. Medicare Part B covers physicians' offices. Medicare Part C is that umbrella that we're talking about that covers everything: the office, the hospital, the prescriptions, the special tests. Those are the ones that you have to get clearance from that insurance company to have your procedures and things like that. It may cover eyeglasses. That's the Medicare Part C. But you may not be able to get anything but generic medications. You may not be able to get. You understand what I'm saying? They confined you as to what you can get. Medicare Part D is the medication part of it only for Medicare. All righty. So those are some of the. I just wanted to break that down for people so you understand exactly this Medicare deal, because I know even as a physician, when I turned 65 and I had to understand it, I had to go back and read it to understand what was going on, to see how I would move forward with that. The last thing I want to put down, I mean, I say put down, say is that there something came through, and I just read this to you, Dr. Bay. The Albert Einstein College of Medicine received a $1 billion donation from Ruth Gottsman, who was a professor at that college. The money is embarked to cover full tuition for students who want to attend medical college. The money is particularly designed for students of color, per Ms. Gottsman, to increase the delivery in the medical profession. The program today is excellent as usual. So
To increase the diversity.
diversity. Diversity. You know, I'm going to have to get a bigger computer here, screen, because the writing's a little small. But the diversity. Thank you, Dr. Salam. Yeah, this is something that has come about in the last few months. Actually, I heard about it some time ago, and it's just wonderful. That's an excellent school. I trust Dr. Anderson was here because he did some of his training at Einstein, and just an excellent physician and excellent training. So if any young brothers are out there and thinking about it, put down Einstein.
So let me just qualify something. There are several medical schools that offer free tuition, including NYU. Albert Einstein is one of the latest, but they might be 7 or so that have tuition free. That usually doesn't mean that it's designed to increase diversity. Okay? And usually most medical schools have fairly rigid requirements for who they accept, because they don't want to accept individuals that they think won't finish. And so there's, as far as I know, there's not any of those dollars that are designed specifically to increase diversity. And if you look at the diversity and you look at the trend that's happened over time, is that I'll say the largest number of entering students into medical school and dental school and in engineering school are Asian Americans. These are individuals of parents might have immigrated or grandparents might have, they were born in the United States, but they make up a significant portion of all the individuals entering into the sciences. So engineering, you name it, dental school, medical school, osteopathic school, everything else. And so if you happen to go to NYU, they don't, and again, when I first hit, they had the Bakke issue of out in California where Bakke sued about this. So a lot of the medical schools dealt with the issue of, affirmative action way back then. And it hasn't changed over time. So the qualifications that the medical schools require for you to get in are unchanged, and they only want best of whoever it is. And you have to do well on the MCATs, have to do well on with your GPA in order to get into medical school. And so if you happen to look, if you're interested in going to and not having the average, which is now over $250,000 worth of debt, if you're going to go to medical school, and it's only increasing, you should look at those schools that offer free tuition and apply. But your ability to get in is going to depend upon whether or not you have good MCATs and good GPAs in the sciences.
Yeah, that is true. There, you gotta be of that standard that they feel that you need to be once you apply to get in. That's for sure. Dr. Salam, please.
Real quick, because I follow this stuff closely. One of the more recent medical schools that they haven't gone tuition free, but they've gone tuition free if you meet certain income requirements, is Hopkins. And so as Hopkins goes, so at least in medicine, so goes the nation. So I think it'll be a matter of time before many of the elites follow in Hopkins' footsteps, because the best and brightest students are going to gravitate towards Hopkins until their peer schools open up those opportunities. But I read a few articles on Ruth Gottesman's gift to Einstein. That money, by the way, is from the she's the widow of Warren Buffett's business partner, and he left her $1 billion to do with in whatever way she chose. And she did, in fact, identify, because the Bronx is the poorest borough, and she really, her thrust was to increase a medical workforce that would serve in these underserved areas like the Bronx. So diversity was definitely a consideration. And a more recent gift was from Bloomberg Philanthropies, where they donated 600 million, 175 million each to the HBCU medical schools, the traditional ones. I know there's some newer ones coming online, but Howard, Morehouse, Meharry, and then they gave 175 to Howard, Morehouse, and Meharry, and 75 million to Drew. And most Black physicians in this country have historically been trained at the HBCU medical schools. So folks realize that this is a pipeline issue, but moreover, you get better, Black patients tend to get better outcomes from Black physicians. That's why this makes so much sense. Sadly, with the death of affirmative action, it has made things a little more challenging, but I think everyone realizes we have major workforce issues in medicine that really have to be addressed so that we can improve health outcomes.
Well,
Kareem, just
No,
one
the
last,
thing is
one
is
last
that,
thing though.
for a
all
minute.
right, all right, this is it. We run over time tremendously, so I'm gonna give each one that want to talk a minute, and that's it. And we're gonna close out today because I appreciate the audience hanging in there with us. Go ahead.
Right. So understanding that, you're most likely to do better when you're taken care of by people who look like you. And we hear all of these philanthropists who don't look like us donating to schools that people like us come from. Where are multimillionaires? Where are billionaires? How are we holding them to account? What are they doing? And sitting down watching others do this. And it's time we begin to call them out. I'm sorry, because in the future, like we're trying to do here, you will not see people who look like you and me, who are doctors, predominantly male. It's a shame, but sadly, something has to be done, and we must begin to hold them accountable as well.
Well, I truly feel, and I feel you, Dr. Aluya, in what you're stating. I think that if you look at the wealth gap and the need of our people throughout, I think that those that are very wealthy, I think a lot of them are doing a lot for us, but the wealth gap and the need is so great that it just doesn't seem like things are happening. But if you really look around, there are some of our wealthy doing a lot for our community. Anyone else have a final word?
Yes. I'm gonna, sure, it's controversial, but I really think in our community, especially among our young men, I feel there's an overemphasis on athletics and not enough of an emphasis on academics. I'm 6'3", and I won't tell you how much I weigh, but I'm not skilled in playing basketball. And I tell people my mother had other ideas for me. I literally read my way out of the hood. And I feel that it's time that people speak up, because there's some folks, some groups of people who will devote an entire weekend to an AAU basketball tournament, and then other groups of people who will devote an entire weekend to SAT prep. And then you have these disparities. But I think to become a physician, it helps if you have average intelligence or slightly above, or as far above as you can get beyond average, but it's certainly not impossible and insurmountable. And I know I didn't start with the best preparation in the world, and I've benefited from pipeline programs, and I've benefited from affirmative action, but I'll stand before any of my peers. I don't care where they went to school. The playing field has been even, and I think we have to send that message. There needs to be more of a focus in our community among our men on academics and a little less on athletics.
Dr. Bay, I'd like to take my 1 minute if that's possible.
Okay.
All right, I agree with everything that I heard, but I do not think that we should be absolved as Black physicians of a role in trying to recruit these male physicians or male students into the profession of medicine. I believe that there can be greater involvement. And I'm just give you a quick case that it's been resting on my mind now for the last maybe year or so. I was called by some people I knew at the American College, American Heart Association. And they called me and they said, Dr. Waldron, we have donated some things to you and you've done some health research for us. How about you mentoring a kid for us? And they sent me a Hispanic kid, which is fine. I believe we can mentor anybody who needs mentoring. To make this story short, this young man came to me, and the first thing he told me, he wants to be a physician assistant. After listening to him, he had an A grade, he had an A average, he was working as an EMT and really an excellent student. And I said, why do you want to be a physician assistant? The quick answer, nobody had ever mentioned to him that he could be a physician. And he had no family member, no role model. To make this story short, I was the one who hooded him at his medical school in August, because I am the one. And he called me to hood him because he said, well, if it wasn't for you, I wouldn't be at medical school. How many Black males are there sitting out there that we as Black physicians could talk them into going to medical school? Mm-hmm. Raise the level of expectation for them. Make them realize that the level that they set for you, you are able to overcome it. Mm-hmm. So we should not be completely absolved, and we should think about it, that maybe we have a role also. It's not only money, but it's also effort that we can get some of these students.
Excellent, excellent. And we're gonna end on that note. I think this was one of, just an extraordinary webinar. I trust the audience got as much out of it that I got out of it, and look forward to the next webinar, the second Saturday of next month, because we'll be here. Hopefully the audience will be here as well. Come on, tell everyone that, it's time to come and be a part of OBHealthy's Doctor's Lounge. Let me end out by saying, number one, thank you to OBHealthy for allowing us to bring this webinar to you. Remember, it's every second Saturday at 1 o'clock. And please, click in on Zoom and type in your medical question. All righty. The most important thing I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor, truly, only your doctor can take the best care of you from a medical standpoint. All righty. And if you've missed any of our YouTube or our webinars, you can go on YouTube, just go to OBHealthy, click the YouTube sign, and all of our past webinars will come up. And also subscribe so we can keep that YouTube going. All righty. And I'm just so proud that each of and every one of these physicians take time every second Saturday to come and educate our people. Thank you, brothers. So from the bottom of my heart, I thank each and every one of you. Look forward to you being here next month. And right now, I'm going to say peace. We went over a little time, but I'm sure the audience, they enjoyed it, and hopefully they got, an enormous amount of medical education out of it. Okay. Thank you very much. Peace, everyone.
Bye.